So our final speaker before our panel with everybody is Dr. Charles Blanke, who's a professor of medicine at Oregon Health Sciences University, the Knight Cancer Institute, and also the chair of the Southwest Oncology Group Cancer Research Network. Dr. Blanke is going to spend some time with us talking about the experience of Oregon and possibly other U.S. states as well. So thank you.
And are you able to see my slides okay?
Yes, thank you.
Fantastic. So it is really a pleasure and an honor to be here. I think you'll find we've come full circle from the first talks this morning, but I hope you will find this to be complimentary. In disclosure, I've actually been consulted on 7 cases by public defenders who wish to use death with dignity drugs in capital punishment cases, which is somewhat interesting, but not a financial disclosure. So very quickly, I'm going to give you a little additional information on the specifics of how death with dignity arose in Oregon, because that set the scene for the rest of the country. I'll hopefully not go over the same material, but talk about implementation of death with dignity elsewhere, at least in terms of a timeline. But then we're really going to dive deeply into the data because we have the longest standing information. And I'll give you a smattering of data from other US venues and then do a compare and contrast. For the last part of this talk, I actually want to give you some anecdotes that highlight some of the legal and other problems I see every week in my clinic, which is solely devoted to end of life. So you've already heard a little bit about this today. In current parlance, it is okay to talk about physician-assisted death or dying or hastened death or dying. Of course, MAID is a common term. Death with dignity is legislative. And the literature tends to use the term lawful physician hastened death. However, most of us no longer refer to this as suicide. As you've heard already, it is not euthanasia, the taking of life of another person. And even though they claim it is certainly not mercy killing. So for those who are not from this part of the country, Oregon is both an incredibly liberal and libertarian state. We were the first state to implement the ability of citizens to enact legislation through popular voting. We have mandatory health care coverage for low-income families, but we have said no to compulsory vaccination and even fluoridation by about 10,000 times by my personal count. Now, you already heard this from Dr. Orentlicker, so I won't go over all of it, but these arguments are made to this day whenever legislative changes are proposed. Everyone quotes the Hippocratic Oath. You're supposed to do no harm. It's going to be a slippery slope to active euthanasia, and you just heard a lot of this from Dr. Donner. It's going to be foisted upon the poorly educated or the impoverished. The last 2 points about prognostication and finances are a little bit more complicated. However, Oregon authors have supplemented these arguments against MAID quite extensively. It's been claimed that MAID is solely the province of the divine and diminishes the sanctity and value of human life, that there is no such thing as rational suicide. My least favorite, that families and patients who are about to die lose the potential for growth when they're actually at the end of life if they shorten their life by their own choice. And my least favorite, we as doctors may utilize MAID when we don't know how to actually manage a medical problem. And the example in the literature was that a surgeon had a patient with a small bowel obstruction, didn't know what to do with it, so they allegedly told the patient to take the MAID drugs. This goes back to Dr. Donner just told us about taking things with a grain of salt. Now, death with dignity has a long history. State Senator Frank Roberts himself had prostate cancer, and he introduced 3 physician-aided dying bills back in the late 80s and early 90s, but none of them got out of committee. Both Washington and California tried and failed in the early 90s to legalize physician-aided dying, but they both allowed euthanasia, and that's always been a non-starter and probably always will be in the US. And in 1993, the Political Action Committee, Oregon Right to Die, was formed. You already heard that 1994 was the passage of the legislation, Measure 16, Oregon Death with Dignity. It passed by 1.31% of the public's vote. It made it for about 1 month before it faced its first legal challenge, and there was a temporary legal injunction placed. And then in the 95 or so, there were a ton of district and circuit court rulings. It became a legal option briefly in 1997, and the first prescription was written in 1998. Interestingly, a month or so later, Measure 51, basically a repeal of death with dignity, was put on the ballot. This time, the proponents of death with dignity did better. About 10% more people supported it. There was a really interesting exit poll that looked at people leaving the voting booth. And by party, 72% of Democrats liked death with dignity, about half of Republicans, and 83% of independents. Not a surprise, they also looked at it by religion, and about 1 in 3 Catholics said death with dignity was a good idea. 40% of Protestants and 90% of those who claimed they did not have any religious affiliation. We then had a ton of trouble, and I remember these days quite well at the federal level. In 1997, Representatives Hyde and Hatch urged the Drug Enforcement Agency to penalize prescribing doctors, and the DEA chief said, hey, that seems like a good idea. In 98, Attorney General Janet Reno reversed the position, saying that doctors would not be prosecuted. So then the Lethal Drug Abuse Prevention Act, again designed to overturn Oregon law, was put forward, but President Clinton said no thank you to that one. In 1999, the U.S. House passed the Pain Relief Promotion Act, which barred physicians from following Oregon law, but it didn't make it to the Senate. And then we really started to sweat, because in 2001, Attorney General Ashcroft said he was going to come after our licenses. He said the prescribing Schedule II medications under death with dignity violated the Controlled Substance Act because suicide is not a legitimate medical purpose. Oregon fought back and said medical practice is a state responsibility. It's not a function of the CSA. And most importantly, the DEA should not tell doctors what to do. Federal Appeals Court in 2004 agreed that doctors should not be penalized, saying that drug control was aimed at drug traffickers, not the practice of medicine. But probably most important for the supporters, Ashcroft retired. In 2005, as you've already heard, this made it to the Supreme Court in Gonzalez versus Oregon, and it was upheld by a 6-3 ruling. Much more recently, there was a poll showing that at least 80% of Oregonians support death with dignity. There have been other polls that I personally believe in other parts of the country with similar numbers. We were a little bit nervous in 2017 when there was an appointment of a Supreme Court justice who had actually written a book against MAID, but nothing's really happened at that level. So you already heard most of this data. I'll just show you that after Oregon legalized it, it took a long time before the second state, Washington, put it into practice. There have been a smattering of others, and now there are 11 venues. I say that instead of states because, of course, Washington, D.C. has legalized it. New Mexico probably has the most liberal legislation, and you know that it mostly passed by citizens' ballot, passed laws, and in Montana only by Supreme Court decision. You also know that this is illegal across the world, and it tends to be a lot more liberal in terms of the requirements, as you've already heard from Dr. Orentlicker. Also, euthanasia is allowed. Switzerland actually did this a long time ago. Colombia is the only Latin America country, a very Catholic area, that allows it. In Australia, it took a number of years, but it's popular throughout the country as well as New Zealand. And I was just consulted by France, by the ministry, because they're really, really interested in pushing this legislation forward. So you've already heard a lot about these, and I'll just hit some of the highlights. We used to have an Oregon residency requirement. We decided that was unconstitutional, and that's been eliminated. Now about a quarter of my practice every week is from patients from out of state, usually Texas, North Carolina, even New York. This life expectancy of less than 6 months is absolutely unbreakable unless the patient is expected to die within 15 days. I am asked all the time to violate this rule, and I'll talk about that later in the talk. As you have probably heard, the prescriber does have to be an MD or a DO and licensed in Oregon. And you heard part of this from a previous speaker. The patient has to be capable of making a healthcare decision for himself or herself, but he also has to be capable of communicating it. The family can't tell you this is clearly what Uncle Ernie wanted to do. In Oregon, we have to tell the patient about alternatives, including comfort care, hospice, adequate pain control, and the patient has to make 3 separate requests for lethal medication. 2 of them are verbal, and 1 of them is in writing. This is really interesting. The patient has to be mentally competent, not when they take the medication, but when the prescription is actually written. And as we already talked about, this is not actually euthanasia. These are some of the more gray areas. For a long time, the state said, you better be careful in helping the patient prepare the medication. Now nobody cares if the doctors do this for the patient. Families don't like to do it, but it is legal. We talked about the mental competence. Technically, a patient could be competent when it's written and then become disabled and still have the medication given to them. The Oregon Health Authority has said it will take our license away if we actually do that. This part is really interesting. The law talks about self-administration, but it doesn't really clearly distinguish between the oral and the IV route. The IV route only comes up in a single clause in the statute, which is actually an insurance clause, which uses the word ingestion. That's been taken to mean that we can give it to them by mouth, we can put it in a stoma if they're wearing a bag after colon cancer surgery, and we can put it into their rectum. But we clearly cannot use an IV even if the patient uses a pump to self-administer it. And we've already been asked this in the questions. Advanced directives remain aspirational, even if the patient's wishes are clearly known. This actually leads to people taking their life too soon, in my opinion. Sometimes people are worried they're going to lose their mental capacity, so they might have 2 or 3 good months ahead, but then be worried they won't be able to self-administer the medication, so they just do it too early. Now, we do have other legislation pending. Some of this mirrors what you've already seen in other states. Senate Bill 891, the Relating to Death with Dignity Act, with no revenue impact and stuck in Senate Committee on Healthcare right now, will allow nurse practitioners and physician assistants to provide death with dignity services. Excuse me, although that's not well defined. This is highly necessary because not that many doctors actually do it, and we're hard to find. It'll also decrease the cooling off period between that first and second request from 15 days to 48 hours. And it expands the people who can actually be a witness to the written request, which is actually fairly restrictive right now. Now, all states do some kind of record keeping, but we do a lot of it. So the Oregon Health Authority requires timely collection of information about participating patients and physicians. We have to file paperwork very shortly after writing a prescription, and we have to file paperwork within 10 days of the death of anybody who's had a prescription written, even if they didn't die from the lethal medication. This includes the demographics, the number of prescriptions written and taken every year, and you can also make special requests, which I did when I published our data in the Lancet Oncology a few years ago. This is good because it maintains patient confidentiality, but it's bad in that it maintains the physician confidentiality and makes this absolutely impossible to find if the patient isn't very computer literate. This is just one example, and I point this out for a specific reason. A lot of times patients say to me, I told Dr. Borgensen 6 months ago I wanted death with dignity. That was my first oral request. That started the clock. And I always ask them, did they inform you of these 5 points? Of course, the answer is no, they did not. And I have to tell them it wasn't the first request. So this limits things a little bit, but it also makes it easier to publish for what it's worth. There's a couple of really, really interesting things in Oregon law that were carried forth in most of the other states. Theoretically, we can't be sued or lose our license or go to jail if we do this in good faith. The prescription does not go directly to the patient, unlike, say, amoxicillin for a strep throat. It has to go to the pharmacy. The good news is the pharmacy will hold it without charging them, but if they want to bring it home, it's about $800, as you heard from Dr. Barnard. Now, we want to dive a little deeper into this. The cause of death has never been suicide on the death certificate. However, it was originally drug overdose legally prescribed, and now it's been changed to the underlying terminal illness. In other words, if a patient with pancreatic cancer takes these drugs and dies as a result, I have to say that they died of pancreatic cancer, which itself is a little bit ethically challenging. But the good news is it protects them from having an insurance company say they won't pay out under a suicide clause. It gets a little bit iffy when I see people from out of state. Theoretically, they should be protected under the same information, if you will. The insurance company will see that they died of their cancer, but they're not specifically protected in legislation, and I tell them they may not be paid out. I wanted to come back to this. You heard a ton of information from Dr. Downer, but I just wanted to highlight one fact. This was actually a poll done by the media quite a few years ago, and you might remember that in Canada, the doctor or a nurse practitioner can administer the drug by IV, or the patient can take it themselves. And you can see that the patients take it themselves in only 0.4% of the cases. They want the physician or medical team to give it to them in 99.6% of the cases. This is really important, although we don't really know the reason why. I suspect there is still a bit of an onus against suicide, even though I've told you 20 times already in this talk, this is not suicide. Others have claimed it's because of certain drug shortages, and it might be because the IV route is more reliable. But I do think that if we made this possible in the US, we would see a similar uptake. And one of the other big differences, you see a lot of patients took the drugs way back when in hospital in Canada. In the US, this happens less than 1% of the time. So these are more specific results. And again, we have the longest standing, about 26 years data. Importantly, there have been more than 3,700 prescriptions for lethal medication written, but only 2,400 plus have been taken. That percentage varies between about 40 and 80% every single year. And there's lots of reasons people don't take the drug. They may get too sick to take it, or they may just want that control. I have plenty of people who put the bottle in their sock drawer and take it out every single day and say, not today, but I could. That's good enough for them. It's good enough for me. It's good enough for the state of Oregon. We have no dog in the fight as to whether they actually take it or not. We just want them to have the right to take it. As you've already heard, death with dignity results, it's not any kind of weird slippery slope. It makes up only 0.6% of total Oregon deaths. Now, there aren't that many doctors who've actually written prescriptions, and more importantly, the overwhelming majority only write 2 or fewer in their entire career. It's not like this is really complicated, but the drugs do evolve and the laws change. So I do recommend that people consult somebody like myself if they're going to do it for the one and only time. In 2022, one physician did write 51 prescriptions. And as you've already heard, the number of prescriptions written every year, as well as the deaths from death with dignity, has gone up pretty steadily with a couple of weird dips, one of which was somewhat near COVID. Now, you've already heard a little bit about the process. I want to highlight this point here. Either the prescriber or the second opinion physician can demand psychiatric consultation if we are worried about mental capacity or competence, but it appears that we're not. This only happened 3% of the time across those years. In many years, there's not any referral at all. So we tend to think we're pretty good at determining decisional capacity. Whether or not that's true, I don't know. We have to advise the patient to inform their family. We can't force them to do it, but most of them do. This is a really interesting number. The prescribing physician is present when the patient takes the medication only about a quarter of the time. I didn't used to ask my patients if they wanted me to be there, but I've learned they do. And since I started asking, do you want me there? The answer is yes, 100% of the time. They're worried about something going wrong. So I ask, and I think that this number is low artificially because we're not smart enough to actually ask the patients if they want that comfort. And as I talked to you about, most of the patients die in their own private residence. Now, I always tell people you don't have to take the medicine, but if you do, you'd better expect to die. These medicines are unbelievably fast acting and they are unbelievably effective. The median time to coma is 5 minutes and the median time to death is 30 minutes. But I also call your attention to this outlier. I myself set the record last month when I had a patient in a coma for 7 days. I always tell people it's not unpleasant for you. You are in a coma, you're essentially anesthetized, you're unaware of any pain or discomfort, but it is so stressful on the families that I repeat it multiple times. They might be asleep for more than a day. Luckily, other complications, including seizures, are very, very rare. And everyone's worried about what if I wake up? That very rarely happens. It's only happened 9 times in the entire history of the act. You already heard from Dr. Barnard a little bit about the medications. We used to use single agent barbiturates. These became difficult to get a few years ago because they were being used in capital punishment cases and they didn't want them used for death with dignity. It was also a pain in the butt because Secobarb came only as 100 capsules. You can't swallow that much plastic and absorb it. So we would have to empty out 100 little tiny time capsules and ream them out with a toothpick. On a good day, that took me 45 minutes. Patients with neuropathy or very ill from their cancer or Lou Gehrig's disease simply couldn't do it. Now we use a 5-drug cocktail known as DDMA-PH, and you can see that the uptake has been nearly universal. That's true, I think, across the United States. These are the actual drugs. I basically tell patients, we give you 2 drugs that either stop the heart or cause it to skip beats, and we give you 3 drugs to make sure that you are asleep, painlessly asleep when that happens. Now, this is an interesting slide because it shows where prescribers are located. And this has actually evolved quite a bit since we were allowed to start doing it by telemedicine. You can still see that the overwhelming bulk of physicians are in the metro areas or surrounding Portland itself. Unfortunately, there remain very few providers in Central Oregon, Southern Oregon, or Eastern Oregon, which are much more rural. I see a ton of these patients every week by telemedicine. Now, these are the characteristics in Oregon of the patients who have taken the medication. You heard a little bit about this from Dr. Donar. They're evenly split between males and females. They are almost predominantly Caucasian, which is what we see in the native population anyway. The age range used to be 25 to 102, although last week I did have a 21-year-old who unfortunately had to take the medication with an incurable cancer. In terms of other patient characteristics, you've already heard a little bit about this. It's not clearly being foisted upon the poorly educated. 3/4 of patients have some or greater college. 92% of patients are enrolled as hospice, although as you've already heard, excuse me, not all the hospices support it, which I find very bizarre. 99% of patients have insurance, but Medicare will not cover it. Most private insurance says no the first time, but I always advise my patients to appeal it. And most of the companies like Blue Cross and United say yes on the second attempt. You've already heard the cancer is the most common. I think in Vermont, you heard this. It's true across the US, making up almost 3/4 of the cases in the US. Lou Gehrig's disease or other neurodegenerative diseases are usually, but not always, in second place. We usually see a smattering of fibrotic lung disease, of congestive heart failure, and a little bit of endocrine disease. We used to see quite a bit of HIV and AIDS, but that is no longer the case. Now, this is interesting. In Oregon, as a physician, I have to ask the patient why they're considering this. They don't have to tell me, but we have to ask them. And 90% of people quote loss of autonomy or just say they have no quality of life. This is something that is very hard to palliate in other ways. It is the Death with Dignity Act, and about 3/4 of people say they've lost their dignity. The numbers that bother me are here at the bottom of the slide. At least 1/4 of patients take the medication because we're not doing a good job controlling their pain. And even more worrisome, theoretically, or more than theoretically, 5% of patients say that they are taking the drugs because they can't afford their chemotherapy. Now, I was asked to talk to you about other data from other states. I won't cover Vermont because you've already heard about that. Washington State, of course, is the second longest venue, as we have seen. They report their data slightly differently. So these are the numbers from 2022. The numbers are pretty reasonable in size. There were 452 participants, and of those known to have died, 81% actually took the drug. Slightly fewer died at home. The average age was what we'd expect at 74. Again, Washington's a pretty Caucasian population. And again, same number, about 3/4 of patients had some or greater college. Cancer remained the most common underlying terminal illness. And again, Lou Gehrig's disease or variants were in second place. Now, again, Washington asks about end-of-life concerns, and we see sort of the same things. A lot of being a burden, loss of autonomy, little quality of life. But again, really bothersome numbers. Half the patients, poor pain control. That is not good for me to see as an oncologist or a palliative care physician. And again, an even higher percentage, 10% said they can't afford their therapy. Now, Montana is special, as you've already heard. Aid in dying is legal there, not through statute, but through a court ruling, 2009, Baxter versus Montana. Since that time, there has been a lot of legislation aimed at peeling it back. They've tried to make the act illegal. They've tried to criminalize participating doctors. They tried to eliminate other physician protections, but all of those have gone down in flames. Why? Because 83% of the voters in Montana support MAID. And interestingly to me, that includes 80% of Republicans who were polled. Otherwise, we do not have formal usage data. California is a big state and they have lots of prescriptions. In 2022, there were almost 1,300 prescriptions written and almost 900 people died from MAID drugs. Same median age, still a very high percent of Caucasian patients. A lot of people took it at home, same exact number, 3/4 of people had some college experience. And again, many of them, most of them, if you will, had some hospice protection. The underlying illnesses are a little bit different in California. Again, cancer was number one, but for whatever reason, and I can't explain this, cardiovascular disease leaped to number 2, and neurologic disease or Lou Gehrig's disease fell to number 3. And again, just a smattering of fibrotic lung disease. Now, New Mexico, here's what I can show you from their website. The statistical data is coming soon. I still applaud New Mexico. They are very liberal. They have a lot of patient protections in place. So I'm very, very curious to see what their usage data really are. Hawaii is also special for a number of reasons. They're ahead of their time. They allow advanced practice providers to participate. They have shortened that cooling off period from the initial request that it were 20 days down to 5. And they also allow it to be shorter, but not as short as Oregon if their death is imminent. They are the only right to die state that requires mental health evaluation. And you can say, wow, it's not necessary because we only do it 3% of the time in Oregon, or you can say that we're missing the boat and we should be doing it. However, it's actually fairly easy in Hawaii because this evaluation can be performed by a licensed marriage counselor or a family counselor. In 2021, there were 49 prescriptions written, and that was their last year with available data. They collect it kind of in a weird way. It's more in list format. So they said that some of the patients, whatever that means, had cancer, ALS, and COPD. The interesting one here is Parkinson's disease. Most of us do not consider it to be Parkinson's disease to actually be a terminal illness. However, people with Parkinson's disease die of other things like pneumonia or failure to thrive because they can't eat. So it kind of depends on how you want to play with the death certificate. And it kind of depends on how you interpret the law. Again, a lot of patients were enrolled in hospice, and for what it's worth, the small number in Hawaii all had a bachelor's degree or better. They were well educated. These are the New Jersey data, one of the more recent states to do it. Now, in this case, as you heard about, I think in Canada, cases are filed with the state medical examiner. Percentage that's high, but not as high, were white. The mean age is exactly what we'd expect, and most, but not quite as many, had some college. Now, this is kind of interesting because the percentage of cancer cases fell to 50%. The percentage of Lou Gehrig's disease rose to nearly a quarter. And again, we see a smattering, fairly consistent, of congestive heart failure and respiratory disease. DC, the only venue or the venue that has this, had a small number of prescriptions written in 2021, the year they reported it. 11 prescriptions written, 8 people died. Age range much smaller than you might see in Oregon, but probably just a function of small numbers. Again, all the patients went to college. And here we see exactly what well, not exactly, but close to what we saw in Oregon, with 3/4 of patients having cancer and about 13% having ALS. Slightly higher percentage of patients had congestive heart failure. Colorado, big state, numbers from 2022, 300 prescriptions, 93% white, overwhelming majority had college, slightly lower percentage had hospice, and again, very, very consistent numbers with 58% having cancer, 14% Lou Gehrig's disease, and then the usual small fractions of heart and lung disease. So maybe boring, I hope not, but I want to point out what we consistently see. The number of prescriptions written has been going up, but it really is a tiny fraction of any state's mortality. The overwhelming majority of patients are white for whatever reason, and I really want to collaborate with New Mexico and New Jersey, which are much more diverse states in general, to kind of dive down into those fractions of patients. Cancer is essentially always the most common underlying illness, and ALS or Lou Gehrig's disease is usually number 2. Most or all patients go to college, and most patients are enrolled in hospice. Again, what bothers me the most, many patients take lethal medication because of uncontrolled pain, and many take it because they can't afford therapy for their underlying illness. So I want to switch hats for the remainder of this talk and just bring up some of the interesting things. Again, this is all I do. I have an average of about 8 new patients a week coming to see me. Again, about a quarter come from out of state. What happens if the patient isn't actually terminal within 6 months? My very first patient ever came to see me with chest wall only breast cancer. For those who do this with a living, you know their median survival is actually measured in years without treatment, and even longer, probably decades if they do get therapy. So obviously I didn't offer death with dignity. I didn't refer them elsewhere for death with dignity, and the patient sued me unsuccessfully, I'm happy to point out. The irony is the patient came back to see me 3 years later with exactly the same amount of disease, and again, asked for death with dignity, and again, I had to say no. In this case, death with dignity is easy. We always say no, but we have to ask ourselves, why do you want it so badly? And you have to ask whether or not you should refer them to psych. If they're otherwise very ill, maybe with something like Parkinson's, we can offer other things like the voluntary cessation of eating and drinking, but again, expected this patient to live for a very long time. I did not offer any way for them to end their life. Now, this is a situation you already heard about from other speakers. What if they have a terminal illness, but it's not going to be terminal if they take therapy? So the classic is a patient with newly diagnosed pancreatic cancer. When I started practicing, it was easy. Even with a standard chemotherapeutic regimen known as 5-FU, their median survival, their average survival, was shorter than that required by law. But now it approaches a year. So if I say to them, if you take therapy, your expected survival disqualifies you from death with dignity, they get pretty mad because they feel like they're losing autonomy. I always tell them, I'm really happy to see you now. Your education was started, even if that 15-day clock was not. And I say, come back and see me after the therapy fails, but before you're too ill to use the therapy. Now, what's really interesting is a ton of people say, nope, not going to take the therapy. Then they do take the therapy. It works. And they come back and see me 3 years later for death with dignity after the therapy has failed. So they do feel they have to hide this, which is probably true. They do actually have to hide it, or else they won't get the prescription. Now it gets a little bit more interesting. I am a GI oncologist by training, and there's a type of stomach cancer known as a gastrointestinal stromal cancer. Late line, their median survival is definitely 6 months without therapy. But some of the new drugs actually cure patients, or at least give them a median survival that is measured in decades. There's no toxicity. And so the question is, if they say to me, yep, I'm going to take treatment, is it okay to start death with dignity knowing that most of them will live for less than 6 months, or do you have to select out the patients they're going to live for less than 6 months? Is more likely than not the actual bar legally for us to use? And here's something that's even weirder. I had a patient who had late line metastatic gallbladder cancer, had gone through all known therapy, but she was healthy as a horse. In fact, she had run a marathon right before she came to see me. If you look at the literature, it says she's going to die within 6 months. And she said, it is my right to get death with dignity. I actually thought, and I was kind of young in my career, she'd be fine in 7 months or 8 months or even a year. But that was, based on a couple of patients that I'd had in the past and not on the literature. So the question is, what do you ethically do? I actually gave her the medication. I don't know why she wanted it. She took it, and her oncologist was really, really angry over this and did not refer me another patient for quite a long time. This made me start thinking about something called the surprise question, which has become very commonly used in death with dignity. It turns out, as you heard from Dr. Barnard, that we're terrible at estimating numerical survival in individual patients, even oncologists. The surprise question came up not in cancer medicine, but in kidney cancer and kidney medicine. Would you be surprised if your patient dies within a year? And it turned out to be really, really predictive in patients who are on dialysis. So there was a study done in patients with metastatic cancer. And we would simply say, would you be surprised to their doctor if they died? And if you said, no, I sure wouldn't be surprised if they died, it turned out that most of them died. But if you said, hey, would you be surprised if they died? And they said, yes, I'd really be surprised. I think they're going to be hale and hearty. Only a small fraction of them died. So it turned out that what we call the positive predictive value, our ability to predict death, was incredibly high at 84%. And the ability to predict life was not as high, but still pretty good. So we have, many of us, adapted this for the 6-month death with dignity eligibility. If I would not be surprised if they were alive in 6 months, I will not give them the prescription. Again, legislation doesn't guide us at all. Now it gets harder ethically. I had a patient who had a cancer of their nasal septum and said, I don't want therapy. I don't want to live without a nose. Now, their median survival is hard to predict because most people do take therapy. But his otolaryngologist said, yeah, he'll probably die within 6 months if I don't do surgery and you don't do radiation. The toxicity, again, was just enormous. So he said, no, thank you. What do you do if they're curable? Well, I offered death with dignity. I got an ethics consult and a psych consult. There's no doubt he was capable, and he did take the medication. Then it got harder. I had a 22-year-old woman with Hodgkin's disease. For those who don't do this for a living, the median survival, if they sit around and don't take chemo, is incredibly short. But the cure rate is 97% with active therapy, and no one really thought that she would have long-term toxicity. We had to ask ourselves, why does a 22-year-old not want the 60 years of life coming to her? But we can't supersede patient autonomy and mandate they take systemic therapy. Does she qualify? Yes, she does, if she doesn't take that chemotherapy. And the question is, should you mandate a psych consult? But I've done this a few times, and these patients are always capable. Many of my colleagues will not offer a prescription in this setting. Then it got harder. I had a patient walk into my clinic with type 1 diabetes and say, Doc, I want the script. And I said, hey, I'm diabetic. You can't have it. I expect to live for several decades. I expect you to live for several decades. And he said, not if I don't take my insulin. And I had to go, is this case really different from those who aren't going to take chemotherapy? It felt different, but in any case, I was let off the hook because his endocrinologist, who was even more uncomfortable, wouldn't sign off on a prognosis, even if he stopped therapy. Then we start seeing things that I'm sure Dr. Barnard participates in or sees every single week. What if they get sick really, really quickly? So I had a patient with anaplastic thyroid cancer that was just growing in front of my eyes. And I was fairly sure he was not going to be able to swallow the pills in 15 days, but he wasn't going to die in that period. Moreover, his death was incredibly likely to be horrible without death with dignity. He was going to suffocate. And I had his family call me every single day, asking me to move up the timeline. Of course, his desires were absolutely crystal clear and unchanging. And I didn't move up the timeline, and he was still able to take the liquid. This is very, very common in ALS. We get people who lose the ability to swallow, or they're paralyzed and they are unable to self-administer. The state does not recognize the potential for the patient to lose the ability to take the medication and will not allow us to take that into account. What if they just had an otherwise crystal clear physical decline? Their wishes were known, they didn't change their mind, but they can't take the medication. You go to their house to help them, and then the family asks you to step out of the room. Well, it's absolutely clear what's going on. The family is going to administer the medication or encourage them to take it. And the question comes up, what do you do? Do you leave? Do you insist on staying? There's nothing, of course, in statute about who polices the procedure for ensuring that it is actually self-administered. What if, and this happens every single week, they make the request, they get the prescription, they have a mental decline right before they take it. The wishes were known, there's no evidence they changed their mind, but you go to their house, their family says, Grandpa, do you want the pills? and those were the secobarbital days. Do you want the medicine? And grandpa says, I want the pills, I want the medicine. And of course, it's incredibly clear they have no comprehension whatsoever that they're going to die. They're just parroting their family members. Obviously, you cannot get a psych consult at the last minute when you go to somebody's house. And what I usually do to make sure there's no coercion, that they are mentally competent, is I actually ask the family to step out of the room and I talk to the patient extensively and privately. But it's very uncomfortable for everybody. I've already told you this is not technically illegal in Oregon, but I have been told I'll lose my license if I do it. So I do not. Now, we are starting to see a lot of people from out of state. They don't have any family here. They don't have a house here. I also see a huge fraction of people who are homeless. So again, they don't have anywhere to take the medication. I've already told you the state requires me to tell them not to take the medication in a public place, although they're not legally forbidden from taking the medication in a public place. The inpatient hospices are not helpful 99.8% of the time. So I started to use local hotels. Then they figured out what was going on, and I've now been banned, I'm not joking, from several hotels in downtown Portland. So I started using Airbnbs, which are actually fairly friendly. I disclose what I'm about to doing with the patient's permission. I'm also comfortable that the hotel gives permission. I have if the patient gives permission to the hotel to tell them what's going on, and the hotel said it's fine, but that's only one hotel in the entire city that I know of. And of course, I can't force the patient to violate their own privacy. A lot of times patients just tell the hotel they're there for terminal care, and the hotel under those circumstances usually says, okay, that sounds fine. The good news is, even if they are in a hotel, the medical examiner will not get involved by statute, even if the patient is not protected by hospice. That was really forward thinking 2 decades ago. Now, there's lots of situations that also apply to the other venues we see across the US. What if the patient's a child? Well, everybody on this call probably thinks, oh my God, that's horrible. You'd never do that, but you might. I've had people consult me because their patient, their son, their 10-year-old had uncontrolled, horrible pain that we simply couldn't do anything about. But you have to be 18 or greater for MAID everywhere in the US. Some do want it available. I don't think that's ever going to happen. What if they have to choose between their hospice and MAID? You might say, that's ridiculous. The hospice is there to support end of life. But many of them are Catholic. Many of them just otherwise oppose anything beside what they see as palliative care. So they say, nope, won't do it. And they actually force the patient to be discharged. Sometimes they leave the room while the patient takes the medication, and then they come back. And of course, regardless, they will not pay for the medication, which you've already heard about from Dr. Barnard, or the consults themselves. Now, we heard a little bit about this, and a couple issues of potential coercion or the opposite of coercion. What if family members strongly oppose it? Well, in my experience, the family members who live with these patients, who see them suffering, of course, don't want their relatives to die, but they also don't want them to suffer. When I hear that somebody doesn't want the patient to do it, it's almost always Cousin George from New York, who hasn't seen the patient for 30 years, but they simply object to death with dignity in all cases. And I simply have to remind the patients family members don't get a vote, and they should ask the family members why they oppose it, because of personal factors applicable to the patient or applicable to the family member. This one is really important. If I see a non-family member who's really pushing dad to take the medication or always speaking on behalf of dad, in my experience, there might be some mental incapacity going on. And I've discovered that it is often for financial reasons. So I always have the person step out and talk to the patient privately. I always, and this is a lesson hard learned, make sure they have a pulse or a DNR form with them. There was one case where a patient took the medication, neighbors looked through the window, saw they weren't breathing, and called 911. The default is for paramedics to revive somebody without a pulse, so they tried to intubate somebody who had just voluntarily taken their own life. This is on the checklist probably of every physician who does this for a living. Now, this is really, really common in Oregon. I can't speak for Vermont. I've already told you they don't have a lot of family support here. So what happens when my patient says, I don't have anyone here, can I bring it back to Idaho? And I say, well, not really. Is it legal for them to transport the medication? It actually is, at least according to my lawyers. In other words, I'm not going to get in trouble for prescribing the medication. Is it legal to take the medications? Well, obviously the patient is not going to be prosecuted. However, I always warn them the family will not be protected against aiding a suicide, which is a felony in a number of states. This has actually been interpreted by a lot of death with dignity experts as not really applying. I tell them, don't take a chance. And of course, there are some of those concerns about the insurance death payment that I discussed with you guys earlier in this lecture. Now, it's really hard to come up with cocktails that work. There isn't formal research like we do in the rest of oncology, where we test a new drug that was developed. Most of the cocktails are empirically derived. There's no toxicity data from animals or early stage patients. And so new cocktails might be fine, or they might just make the patient really, really sick without them dying. The patients are always their own guinea pigs who don't actually give consent, and I really don't like that. No one regulates off-label use of these medications, not the pharmacology boards and not the state medical authorities. So it's a big problem. And the rest of us have to really decide, how much evidence do we need to know that a new regimen is better? You saw some of that uptake with DDMA-PH, but it took a little while, for example. So my conclusions are about 2/3 of the patients who are given the prescriptions across the US take them, but a third don't for a variety of reasons. I do always tell my patients the medications are lethal and fast acting, excuse me, but other complications are rare. And while we do see the number of prescriptions rising annually everywhere, MAID deaths are a tiny fraction of overall resident mortality. At least in the states who currently use the drugs, the patients are elderly, white, and very well educated, genders fairly evenly split. Most or all of the patients take the medication at home. If you treat cancer for a living, you're going to see this. If you treat Lou Gehrig's disease for a living, you're going to see this. In general, the major end-of-life concerns across the US are loss of autonomy, inability to enjoy life, or poor quality of life, and loss of dignity. As a researcher and a practitioner, I think we need to do some research in this area. Why don't 1/3 of the patients take the medication? Why are some of the people asleep for 6 days? What could we learn that we could at least warn families or patients? How do we palliate end-of-life concerns better? And this is a big one, because some psychiatrists say that treating depression would make the urge for death with dignity to go away, and say that we should not offer death with dignity because that diminishes decisional capacity, which I disagree with. With that in mind, I will stop sharing, and I guess I welcome the panel. Thank you very much.
Thank you very much. Before we hop into the panel, there's a question that's come in through the Q&A that we'd love your feedback on. Do we know anything about the political affiliations of patients who use MAID in Oregon?
Not of the patients. I've privately asked them, and just through my experience, they tend to be incredibly liberal, but that also reflects the general population.